We're
Sure.
participating in this Zoom meeting tonight from the lands of the Coast Salish peoples. If each of you can take a minute to acknowledge the people in the lands where you're joining us from today. We are engaging in efforts to achieve universal health care. We will discuss equity in healthcare for immigrants from all over the world and for Indigenous peoples who are immigrants from the lands that have been stolen from them. We acknowledge all of the ancestral homelands and the traditional territories of the Indigenous peoples who have been here since time immemorial. Our efforts to achieve equity in healthcare shall include universal healthcare coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations.
We are really honored to have Kip Sullivan here, who has agreed to give us some of his very valuable time to detail the very current threat to completely privatizing Medicare going on now under our very noses. Kip is an important resource for PNHP, One Payer States, many other organizations, and also carries on a voluminous current online discussions, helping people understand to questions that they ask him and things that come up. His advocacy goes back to 1970s, graduating from Harvard Law School in 1972, but his passion has really been to put the for-profit insurance industry out of business, as we'll definitely hear tonight. He co-founded the Minnesota chapter of PNHP in 2007 and was a board member in 2000 until 2014, and also helped found Healthcare for All Minnesota, and has been on its board and is now an active advisor to the board. So I don't think I need to tell you what Kip is going to talk about, but he has a slideshow that's got tons of information in it, and it'll be available to everybody who wants a copy of it, and I'm sure you all will. And we're also recording this, and we'll put it on our PNHP Washington YouTube site in a day or two. So Kip.
All righty, thank you. I'm going to discuss the twin threats to Medicare, the Medicare Advantage Program and Medicare's ACO programs. ACO stands for Accountable Care Organization. Those two programs, Medicare Advantage and the ACO programs, are privatizing Medicare. As of this year, 2022, the two programs together have privatized 72% of the Medicare program. In other words, 72% of all Medicare beneficiaries are in one of those programs. 50% are in Medicare Advantage and 22% are in one of the ACO programs. The big one being the Medicare Shared Savings Program. The other sizable one is the DCE, Direct Contracting Entities Program, which will be called the REACH ACO program come January 1, 2023. Last year, in 2021, 70% were in one of those programs, Medicare Advantage or ACOs. And 2 years ago, 67% were in one of those programs. Privatization of Medicare is increasing by 2 to 3% annually. At that rate, Medicare will be totally privatized in 10 to 15 years, possibly by 2030. If privatization cut costs or improved quality, we would have no reason to oppose this trend. But privatization has not cut costs or improved quality. Moreover, it has accelerated consolidation, and it has shifted authority from doctors and patients over medical decisions to distant bureaucrats. Thanks to PNHP and several other organizations and to some brave members of the U.S. House, including Representative Pramila Jayapal, we are beginning to see resistance to pell-mell Medicare privatization. Unfortunately, the corporations that stand to make money off privatization have grown wealthier and more organized over the decades. Even more unfortunately, CMS has become a powerful proponent. Centers for Medicare and Medicaid Services has become a powerful proponent of privatization. Over the last 2 decades, CMS has become more fervently pro-privatization. CMS under the Biden administration is as passionate about privatizing Medicare as it was under the Trump administration. The Biden administration made its devotion to privatization crystal clear in a white paper entitled Strategy Refresh, published a year ago. In that paper, CMS announced its intention to push all Medicare beneficiaries into ACOs or Medicare Advantage by 2030. What is most astonishing and disturbing about that Strategy Refresh paper is CMS's utter indifference to evidence. We have 40 years of research demonstrating that Medicare Advantage doesn't work and 10 years of research indicating ACOs don't work. Amazingly, CMS admits early in the white paper that ACOs haven't worked. But then they go on to assert that the CMS have learned lessons from the failed ACO programs, and when they apply all these wonderful lessons, ACOs will work at long last. They will not only cut costs and improve quality, they will somehow improve equity. CMS says equity over and over in the white paper and in other documents describing the DCE, direct contracting ACO program, the one that will become the REACH ACO program on January 1. Let me read to you some of these quote unquote lessons learned. Now, this is directly from the Strategy Refresh paper. Underserved beneficiaries will have increased access to accountable value-based care. What in the world might that be? Underserved beneficiaries will experience improved quality and outcomes. The CMS Innovation Center will offer targeted learning opportunities for model participants. Beneficiaries in accountable care relationships will receive more person-centered integrated care. Providers will receive support to leverage actionable practice-specific data. You got to be trained to talk that funny talk. These are not lessons. They are daydreams expressed in the most abstract terms possible. Accountable value-based care, targeted learning opportunities, person-centered care, actionable data. The Strategy Refresh paper does not offer a single footnote to support these vaguely articulated daydreams. Moreover, the paper says nothing at all about Medicare Advantage. We may infer there will be no Strategy Refresh for Medicare Advantage. It's going to be the same old, continuation of overpayments and little or no effort made to keep the Medicare Advantage plans from abusing patients. As the agency that administers Medicare, CMS should see itself as an honest broker of information about Medicare. That is not how CMS sees itself. CMS thinks its job is to function like an advertising agency hired to promote the privatization of Medicare. The Strategy Refresh paper reads like an advertisement. It ignores evidence and makes numerous boasts with lavish use of abstract and manipulative buzzwords and happy talk. CMS should have published a white paper telling the public that Medicare Advantage and CMS's ACO programs have failed, and explaining why they failed, and promising to terminate the ACO programs and to urge Biden to terminate Medicare Advantage. I want to take a few minutes to summarize for you what such a paper should say, and then I'll bring up some slides that illustrate and document what I've said. The paper that CMS should have published would begin with the statement that the MA and ACO programs have clearly failed on 2 counts: to cut costs or improve quality. It would then address the question, why did this happen? The answer is because proponents of Medicare privatization, that is of Medicare Advantage and of the ACO programs, adopted the wrong diagnosis and the wrong solution. They assumed without evidence that Medicare beneficiaries were getting large amounts of medical services they didn't need, and they blamed this alleged problem on the fee-for-service method of paying doctors. There was a kernel of truth to this argument. The fee-for-service payment method does create an incentive for doctors to order services patients don't need. but there is no evidence to support the claim that doctors cave in routinely to that incentive, or that overuse is the main reason Medicare costs were rising in the late 60s when the overuse myth was launched, or that US costs are double those of other nations for that reason, because of overuse. The myth that excessive volume of medical services causes high Medicare and US healthcare costs was started in 1970. For the first time in American history, in the late 1960s, healthcare inflation had become a political issue. And healthcare costs in Medicare were rising because prices were rising. Medicare had just been implemented in 1966. Doctors and hospitals were raising prices because they could. Medicare at that point wasn't doing a great deal of limiting prices. The problem then for both Medicare and the country was rising prices, not increased utilization. But a Minnesota physician named Paul Elwood almost single-handedly convinced the Nixon administration and Congress that excessive use of medical care was the problem. And the reason Americans were getting too many medical services was this darn fee-for-service method by which doctors are paid. There was no evidence for this diagnosis in 1970 and none now. Having convinced Nixon and Congress of his evidence-free overuse diagnosis, Elwood then proposed his evidence-free solution, a newfangled form of health insurance that he called the HMO. The HMO would expose doctors to capitation and similar financial incentives to order fewer services. And just in case capitation didn't induce doctors to reduce services sufficiently, HMOs would micromanage doctors. And I think everybody here knows what capitation is, but just to make sure, it's the anti-fee-for-service. It's the opposite of fee-for-service. Doctors, hospitals, insurance companies are paid a fee per head, per enrollee, per patient for a year. And it doesn't change depending upon the amount of service, medical care that a patient needs. And I won't explain this further, but it's important to state that if you want to capitate doctors, you have to limit patient choice. You can't have patients running around everywhere and sending the bill to their to the doctor who's been capitated. Elwood never presented a shred of evidence for his diagnosis, overuse due to fee-for-service, nor his solution, HMOs, but his flimsy analysis attracted immediate support, and in 1972, Congress inserted HMOs into Medicare. That's where the Medicare privatization problem began. And in 1973, Congress passed the HMO Act of 1973, which subsidized the formation of the planet's first HMO industry. In 1997, Congress allowed all types of insurance companies into Medicare, PPOs and traditional insurance companies, in addition to HMOs. And they named the program Medicare Plus Choice. In 2003, Congress renamed it Medicare Advantage. And now Medicare Advantage is enrolling 50% of all Medicare beneficiaries. Where are we? So over a 50-year period, HMOs were first inserted in 1972. Here it is 2022, and half the program is taken over by insurance companies. Note that this toxic chain of events was triggered by the false diagnosis that overuse due to fee-for-service is the problem that has to be solved. Another question Congress did not address before inserting HMOs into Medicare was, how can HMOs or any insurance company of any stripe save money for Medicare if the insurance companies have to spend 15% of their revenues on administrative costs? And when I say administrative costs, I'm including profit. I just don't want to have to keep saying administrative costs plus profits. Is there really that much overuse to cut? And even assuming there is, are Medicare Advantage plans capable of cutting medical services by 15% or more without harming patients, without cutting necessary services? Congress didn't ask that question. The answer to that question is obviously no. How then, you ask, did HMOs and later MA plans not only survive in Medicare, but take over 50% of the program and make a huge profit? The answer, they were overpaid, perhaps as much as 30% during the 70s, 80s, and 90s, and 10 to 15% today. How did that happen? Between 1972 and 2004, overpayment was caused by two factors. One, HMOs enrolled beneficiaries who were above average health. That's called favorable selection. But CMS paid the HMOs as if their beneficiaries were in average health. That was mistake number one. Number two, prior to 2004, HMOs denied services, including necessary services. Since 2004, Medicare Advantage plans have used a third tactic. It's called upcoding. You add codes you shouldn't to the claim form to make your patients look sicker. I'm going to review each of these tactics. We already have evidence that ACOs are using these same three tactics. All right, first, favorable selection. HMOs and Medicare Advantage plans have always enjoyed favorable selection for two reasons. One, Medicare Advantage plans market to healthier people, and they induce sicker enrollees to disenroll by frustrating them or refusing to contract with doctors and hospitals that treat sicker patients. Two, healthier beneficiaries are more willing to give up choice of provider in exchange for the more benefit, the richer benefits that Medicare Advantage plans can offer because they're overpaid. CMS has never been able to ratchet down its capitation payments, its premium payments, its per enrollee payments to Medicare Advantage plans sufficiently to avoid overpaying them.
Oh, hold on just a minute. Can you find
Tactic number two, denial of services. We're talking about how Medicare Advantage plans.
yeah.
All right, we're discussing the three reasons Medicare Advantage plans have been vastly overpaid. We've covered favorable selection. Now we're talking about denial of services. This is accomplished partly with financial incentives to doctors, but mainly through utilization review. And thirdly, upcoding. Since 2004, MA plans have used a third tactic to make enough money off Medicare to cover their overhead costs and still make a lot of money. That's called upcoding. Prior to 2004, upcoding was not possible. Prior to 2004, CMS did not use diagnoses to adjust its premium payments to Medicare Advantage plans downward to reflect the superior health of their enrollees. That process of adjusting premiums to reflect the health of enrollees is called risk adjustment. CMS, prior to 2004, only used age, sex, Medicaid status, and nursing home status to predict the costs of Medicare enrollees. But those four factors, called demographic factors, were almost worthless as predictors. They explained or predicted only 1% of the variation in spending on beneficiaries. I was surprised when I first heard that, but that's a fact. It's all you have that information, you plug it into your computer, you've almost predicted nothing. So let me give you an example of what it means to have a risk adjuster that's that lousy. Let's say that the average cost of insuring a Medicare beneficiary is $10,000, and Humana's enrollees cost $9,000 on average. CMS should reduce its premium payments to Humana by $1,000 per enrollee and pay them only $9,000. If CMS's risk adjustment method is almost worthless, CMS will pay Humana $10,000 per enrollee, and Humana will make $1,000 per enrollee for no good reason. And Medicare's costs will have gone up. Because if that enrollee had stayed in fee-for-service Medicare, Medicare would have had to pay $9,000 for the services. In 1997, Congress ordered CMS to improve its risk adjuster. CMS added several thousand diagnoses to the four demographic factors, sex, age, Medicaid, nursing home status, and phased in the new diagnosis-based risk adjuster between 2004 and 2006. Now the MA plans had a huge incentive to make their enrollees look sicker than they were. And they did that by upcoding. And I'm going to give you some examples when I get to the slides, by entering exaggerated or flat out fraudulent diagnoses. This they have done with gusto. To make matters worse, CMS's new diagnosis-based risk adjuster is not much more accurate than its old demographic risk adjuster. It explains only 12% of the variation in spending. This means CMS is still vastly overpaying for the healthiest Medicare beneficiaries and vastly underpaying for this gives insurance companies and ACOs who are risk adjusted the same way. Tremendous incentive to cherry pick and lemon drop. Now, if CMS had published a white paper explaining why Medicare Advantage and ACOs have failed, CMS would have concluded the section on the failure of Medicare Advantage with a statement like this, quote, Medicare Advantage plans have failed because the original excuse for inserting insurance companies into Medicare was false. Rampant overuse due to fee-for-service or any other reason does not exist. Moreover, privatization proponents overlooked the enormous administrative costs Medicare Advantage plans generate. Medicare Advantage plans were able to take over 50% of Medicare, not because they figured out how to cut overuse by enough to cover their high administrative costs, but because they've been overpaid. They've been overpaid, one, because we at CMS have never been able to risk adjust their premium payments downward enough. Two, because MA plans deny necessary services, and we at CMS have been unable to stop that. And three, because they upcode, and we at CMS have been unable to stop that too. End of suggested opening paragraph. Now let's turn to what CMS should have said in the white paper about the failure of ACOs. ACOs were invented in 2006 and inserted into Medicare in 2010. For the same bogus reason, HMOs were inserted into Medicare in 1972. The passionate, evidence-free belief that somewhere some doctor who's paid fee for service is ordering services patients don't need, and someone's got to do the dirty work of making them stop it. We need ACOs in the traditional Medicare program, that part of the program that hadn't been taken over by Medicare Advantage, to stop those darn doctors from ordering all those unnecessary services. The ACO was invented by MedPAC in 2006, and it was endorsed by the Affordable Care Act, which was enacted in 2010. ACOs are very similar to Medicare Advantage plans or the old HMOs, especially the latest iteration, the DCE-REACH ACO. The most important differences between ACOs and Medicare Advantage plans are ACOs acquire members by assignment. CMS assigns beneficiaries to ACOs, whereas Medicare Advantage plans enroll their members. Now, the fact that ACO members are assigned makes it more difficult for them to cherry pick, but they still are able to do it to some degree. The second difference between ACOs and HMOs or Medicare Advantage plans is that ACOs, in theory, cannot require their assignees to seek care only within the ACO network. How CMS enforces that prohibition, I don't know. I'm quite sure they don't. In all other respects, ACOs are identical to Medicare Advantage plans. They have the same incentive to get rid of sicker assignees and to exclude from their networks hospitals and clinics that treat sicker patients. They have the same incentive to deny services to the sicker people they can't avoid and to upcode. CMS uses the same lousy risk adjuster to adjust its capitation payments to ACOs that it uses for Medicare Advantage. Now, if CMS had published a white paper explaining why Medicare Advantage and the ACO programs have failed, here's my suggested conclusion for the section on ACOs. Quote, ACOs have failed for the same reason Medicare Advantage plans have failed. There's not much overuse to cut, and ACOs have to pay for their overhead. How are they going to do that other than to be overpaid? Now I want to bring up the slides. I would like to limit the discussion of the slides to about a half an hour. I've crammed a lot more into these slides than I can discuss tonight. What I'm going to do is rush through some of them, take my time on others. But I really want you to know all the major issues that are out there to be discussed. I'd be happy to take questions about the issues that I don't have enough time to talk about, either by email or another meeting. Here is the smoking gun from the CMS Strategy Refresh document in blue. CMS has set the goal of having every Medicare beneficiary in an accountable care relationship by 2030. I don't know what an accountable care relationship is. I think what it means, it's CMS's euphemism for, we want to cram you into a Medicare Advantage plan or an accountable care organization. if they're going to use euphemisms, they're going to have to, I think that that's a fair interpretation of their euphemism. This blue sentence appeared on page 14. This darker sentence appeared on page 13. So in the context, I think it's fair to say what CMS is telling us is they want all Medicare beneficiaries in either a Medicare Advantage plan or an ACO by 2030. To add to the objectionableness of this document, they go on to say, oh, and we'd like to reinvigorate the national push toward value. Another euphemism. I think what they're saying is we'd like to also encourage insurance companies and Medicaid to push more of their enrollees into ACOs. Now, CMS just loves this phrase, lessons learned. It's their excuse for saying, yeah, we understand the track record of ACOs isn't very good, but we learned a lot. So you see here in the top bullet that they said in their frequently asked questions document posted in October of 2020 about the DCE program, the DCE program leverages lessons learned from other ACO initiatives and Medicare Advantage. Boy, if you're learning lessons from ACOs and Medicare Advantage, the lesson should be shut them down. You don't continue to tinker with ACOs based on the lessons from those programs. And here you see another statement from the refresh document. CMS has learned significant lessons from its ACO initiatives. Now, I'll take a look at this last sentence. What lessons have you learned, CMS? For instance, the CMS Innovation Agency is examining its benchmarking and risk adjustment approaches to provide incentives to encourage participation. What if Boeing, after a plane crash, were to say, we learned a lot of lessons from the plane crash, and we're going to be studying new methods of encouraging more people to fly in our planes? It's not rational. It's not telling you that they have any understanding of why the plane crashed. I read to you some of these quote unquote lessons learned from the strategy refresh. Underserved beneficiaries will have increased access to accountable value-based care. Well, yeah, really? Here's another one. They will experience improved quality and outcomes due to CMS efforts. CMS is going to focus. Here's the data on privatization that I mentioned. Let's just focus on the 2022 column. You see that in that year, this year, 72% of all Medicare beneficiaries are in either an ACO or one of the MA plans. You see that the bulk of them are insured through a Medicare Advantage, and 22% are in one of the ACO programs, the big one being Medicare Shared Savings. The Direct Contracting Entities program started out last year. This year, they've got 3% of all Medicare beneficiaries. There's a few dinky little ACO programs. They're so small, they don't register over 0%. And you see the numbers changing from 2020 to 2021 to 2022. Privatization is increasing at about 2 to 3% per year. Now, I want to just go over a couple of slides that demonstrate the document, what I said. Medicare Advantage is not saving money, and the ACOs are not saving money. This is a report from the Medicare Payment Advisory Commission, set up in 1997 to advise Congress on all things about Medicare. You can't get on MedPAC unless you're enthusiastic about privatization, but here's what they said. They said the Medicare Advantage program has been expected to reduce Medicare spending, but private plans in the aggregate have never produced savings for Medicare. Here's evidence indicating the same thing on ACOs. Most of this is from an article that Jim Kahn and I wrote for the Journal of General Internal Medicine a year ago. You see that the first ACO demonstration, called the Physician Group Practice Demonstration, saved a marvelous total of 0.3%. And in fact, if you included upcoding, they lost money for Medicare. The Pioneer ACO program saved a few 0.1%, but again, if you counted upcoding, they probably lost money. The MSSP, the Medicare Shared Savings Program, lost money in its first 4 years, and according to CMS, is saving a few tenths of a percent since. I put a question mark here on the 1% number for 2021. There are several reasons to doubt that. The effect of the COVID epidemic, and a law that I hope we have time to discuss tonight, the merit-based incentive payment system. It's a program that was Congress passed in 2015. It's designed to give doctors a financial incentive to join ACOs. If you're a doctor, you're not in Medicare Advantage, you're traditional Medicare, and you don't join an ACO, you're going to lose some of your Part B reimbursement. And if you do join an ACO, your Part B reimbursements, you'll get a 5% bonus for 5 years in a row on your Part B payments. That's a sizable subsidy for the any ACO program, and those subsidies kicked in 2019. You never hear those subsidies counted when CMS or other analysts are reporting to us whether they saved or lost money. Nor has Medicare Advantage improved quality. This slide, it contains excerpts from a report in the New York Times last spring about a devastating report from the Inspector General within the Health and Human Services Department. Essentially, they found that Medicare Advantage plans are denying services hand over fist. You see here in blue the highlights. This Inspector General said they found troubling evidence that the Medicare Advantage plans are delaying or preventing Medicare beneficiaries from getting medically necessary care. The Inspector General reported that 13% of the requests that were denied should have been covered. Here's another excerpt from that article. A horror story about an 87-year-old man in Indianapolis with kidney and heart conditions. His doctor recommends inpatient rehabilitation. Humana has repeatedly refused to authorize it. We've known this for a long time. This is a study from the 90s in JAMA, comparing the quality of HMO care. Remember, prior to 1997, only HMOs could participate in Medicare, and fee-for-service Medicare. Declines in health were far more common amongst the HMO enrollees. ACOs also reduce quality, but we don't have anywhere near the evidence on the impact of ACOs on quality that has accumulated on HMOs and Medicare Advantage plans. We do have one very disturbing article published in Health Services Research in December 2018 by Denise Tyler and her colleagues. And essentially what this article found was that ACOs, in some ACOs in the Midwest, they didn't identify them, are enforcing an arbitrary deadline of 17 days on skilled nursing facility length of stays, LOS. Who knows where that 17 days came from, but Tyler and al. Found it and reported on it. You'll be shocked to learn CMS hasn't done a thing about it. I don't think they even know about this abuse. I don't think they bothered to read the article. Here's her excerpts from the article. Staff in these skilled nursing facilities reported pressure from hospitals participating in ACOs. The hospitals, the ACOs, are insisting that they kick their patients out at 17 days. Now, here's a quote from one of the nurses. "I'm not very happy with that 17 days. Some patients are really sick and need the extra days, but then because it's like cutoff time for you, you do whatever." This director of nursing goes on to say, this issue has been worsening lately. And the nurse says, "So I put my feet down, and most of the time I fight for this, but I don't always win. It wasn't like this before, but now the length of study is being cut off slowly." Why is this happening? Could it be that ACOs are enrolling more Medicare beneficiaries? Now listen to this. One facility that had reduced its length of length of stay learned how to remove patients from ACO participation. I think you all know that once you get swept into an ACO, you can't get out unless you change doctors. My mother, that just happened to my mother. And if we've got some time, I want to tell you what I have done since that happened. But here's the quote. we secretly get them to switch to a non-ACO doctor, and then they're automatically out of the ACO and they can use their 100 days. But they hope the ACO doesn't find out. That's disgusting. Now, CMS claims that this kind of abuse, this just simply won't happen with the ACO-REACH model. They say in a fact sheet posted last February, like previous ACO models, the ACO-REACH model prohibits restricting care. Bunk. I mean, why should we believe that if an article appears in Health Services Research, numerous nurses testify to it, and CMS didn't lift a finger? I don't think they even know about it. Here's a brief outline of the remainder of these slides. There's a lot here that I'm not going to discuss, but I want to apprise you of issues that I think ideally you should know something about, especially if you're going to be lobbying legislators who have drunk the ACO Kool-Aid. I won't talk about definitions. I've got a slide on that just in case there are people who look at this later and would like to know some definitions of jargon. I do want to spend some time debunking the overuse diagnosis, and I'm going to spend some time documenting that ACOs and Medicare Advantage plans have high overhead costs. Again, we don't have a lot of evidence on the overhead costs of ACOs, but we're going to eavesdrop on an earnings call by one of the DCEs, Oak Street Health, where they tell us that their overhead is about 20%. I want to talk a little bit more about these profit-making tactics, the tactics that the ACOs and the Medicare Advantage, the Medicare Advantage plans have used to survive in Medicare and make a ton of money, even though there's not a whole lot of overuse to cut, and they have overhead. We can expect that ACOs have no other option than to do exactly what the Medicare Advantage plans have done, which is to achieve favorable selection by cherry picking and limit dropping, denying services, and upcoding. The ACOs, as I said, have one other advantage. They're subsidized by this merit-based incentive payment system since 2019. And it may be that investors who are buying up these ACOs are thinking that maybe ACOs really aren't going to be as profitable as the MA plans have been, but they'll make themselves profitable by signing contracts with the MA plans and then using their contract with CMS for direct contracting REACH ACOs to steer their assignees into Medicare Advantage plans. If they do it overtly, they could get in trouble with the False Claims Act. They may be sued. So if they do this, they will do it under the radar. There are several topics I won't have time to discuss, but I really think we should discuss them at some point. CMS is claiming making three claims for the REACH ACOs. They're saying they're going to achieve greater equity with little health plans. Like what? We're going to hire some people that speak Spanish. They claim they're going to give them a tiny subsidy for some of their poor assignees. CMS is claiming they're going to do a better job of screening applicants. Well, I guess we'll find out soon if they accept Amazon, right? What about Walgreens? They just bought out an ACO. And they claim they're going to do better monitoring to detect abuse. I'll believe that when I see it. I won't have time to cover two other important issues. ACOs and Medicare Advantage encourage consolidation, and they worsen burnout amongst doctors and nurses. Here's my definitions list. Going to jump over it. I do want to talk just for a second about the medical loss ratio. I think you all know what that is. We first heard the term in the summer of 2009 when Democrats were thinking about making Medicare Advantage plans and insurance companies more efficient by forcing them to spend a minimum amount of their premium revenue on patients. So they developed these ratios. So for the insurance companies that insure big groups, the minimum medical loss ratio is 85%. Insurance companies have to shell out 85% of their premium revenue for patients. I say that because in a minute, we're going to talk about a medical loss ratio for an ACO. Why shouldn't we? They're not that different from HMOs. They're insurance companies. I'm not going to dwell long on the next 5 or 6 slides. what these slides that I'm going to show you now tell you is that nobody knows what an ACO is. When MedPAC sent over its report to Congress in June 2009, recommending ACOs, all they could say was they are a set of physicians and hospitals that accept joint responsibility. What does that mean? Who are you accepting? Who's going to hold them accountable? How? But the goal, they say, is to constrain volume. Here we go again. Just as Elwood was telling Nixon and Congress in 1970 and 71 that we need HMOs inserted into Medicare, but these darn doctors are causing an outrageous amount of volume due to fee-for-service. We're hearing the same thing 40 years later. Why we have to, the same excuse for why we have to put ACOs into the traditional Medicare program to constrain volume. More definitions that I'll let you look at later. Here's one of my favorite comments. This is from a MedPAC commissioner, Jack Hoadley. They were discussing the problem that nobody knows what an ACO is. And Hoadley says, I don't know what it is. I think even a lot of smart people have trouble explaining to somebody, maybe their own parent, what this is. Here's my favorite definition. ACOs are HMOs in drag from Kaiser Health News. Pretty close. But let's, just to be serious, let's talk about the differences between ACOs and HMOs. The big one is HMOs acquire members through enrollment, ACOs through assignment. And as I've already said, that makes it harder for ACOs to cherry pick. For that reason, they may not make as much money as Medicare Advantage plans have. They're going to have to rely on limit dropping, denial of services, and upcoding. The second difference is that the early ACO programs required ACOs to share risk with CMS rather than to bear all risk, that is, to enjoy all profits and suffer all losses, which is what Medicare Advantage plans do. In the latest ACO programs, Next Generation and the REACH programs, the ACOs have the option to take all risk, to be paid just like an insurance company, premium and capitation payments. So this difference is no longer a difference for the ACOs that choose to be paid a premium. The third difference is that ACOs are not supposed to force assignees to stay within the ACO network. You know that is not being honored in the letter of that law is going to be easily violated. I don't know if everybody knows how ACOs get their members, so just to make sure we're all on the same page, let me go through that process. It's a two-step process. CMS assigns all traditional Medicare beneficiaries, and when I say that, I mean all beneficiaries who are not in an MA plan. CMS assigns all traditional Medicare beneficiaries to a primary care doctor based on the plurality of visits by that beneficiary during a look-back period, typically of 2 or 3 years. Beneficiaries, second step, beneficiaries who are assigned to doctors who have contracts with ACOs are then assigned to those ACOs. And the mystery I'm trying to figure out with my mother is, what doctor did she see that was in an ACO? She's in an ACO called Health Partners here in Minnesota, and she never visited a Health Partners doctor to our knowledge. I can tell you more about that later. I filed a freedom of information request, by the way, with CMS. Now I want to get to the issue of the overuse excuse. Here again is the major dates in the rise of the overuse myth. In February 1970, Dr. Paul Elwood, father of the HMO, meets secretly with Nixon representatives at the DuPont Plaza Hotel in Washington, D.C. They hash over the overuse myth, and they invent the HMO as the obvious thing to do if overuse is rampant in Medicare. 2006, MedPAC and Elliot Fisher invent the ACO for the same reason. Overuse is occurring in Medicare. Someone's got to stop it. In 2009, MedPAC formally recommends the ACO to Congress, and in 2010, Obama signs the Affordable Care Act endorsing ACOs. The original intellectual sin of the privatizers was they picked the wrong diagnosis. If you're concerned about total spending in any sector of the US economy, be it bananas or healthcare, you have to be concerned about two numbers: the price of bananas and the quantity sold. Price times quantity in the course of a year gives you total spending. Elwood and the privatizers adopted the quantity diagnosis out of thin air. Price was the appropriate diagnosis. If they wanted to know why were Medicare prices rising in the early 70s when Elwood met with Nixon's people, it's because prices were going up. If you want to know why U.S. costs are double those of the rest of the industrialized world, it's because our prices are obscene, not because Americans use twice as much healthcare. That's what this study that I cited here reported, and several other studies have reported that as well. It's the prices, stupid. That's the actual title of this article by Gerard Anderson at Johns Hopkins and Yuba Reinhardt at Princeton and one other author. But come 2009, when it was time for the Medicare Advisory Commission to urge ACOs on Medicare, what did they say? We need the ACOs to overcome the incentives in the fee-for-service system to build up volume without improving quality. Volume is the problem. The current unrestrained fee-for-service payment system has created a rate of growth that's unsustainable. It's a monster. And note that we have a new mantra now. You can't hold your head up at a health policy conference if you don't know how to say volume to value. Now I want to introduce you just to one of the numerous studies we could talk about that documents how little overuse there is out there. This is a study that appeared in the Archives of Internal Medicine in 2012. I've looked at subsequent research. It hasn't been contradicted by Deborah Korenstein and colleagues. They looked at research over the last 30 years looking for documented evidence of overuse. And they found very little. They said it's limited to a few services. They said the majority of studies focused on 4 interventions: antibiotics for upper respiratory infections and 3 cardiovascular procedures. Now, the editor of Archives of Internal Medicine was so blown away by this finding, because he's like all of us who study health policy. You hear about overuse constantly. He was blown away by this finding. So he wrote this little editorial to accompany the article. He said, what is most striking about this report is how hard the authors searched for data on overuse and how little they found. They viewed 31 years of research and evaluated 115,000 publications, yet found only 172 articles that addressed overuse. The second intellectual sin that the privatizers committed was to totally ignore administrative costs. Now, of course, administrative costs are generated at 3 levels. The MA plans, the ACOs have them. They generate more overhead costs for providers, and CMS incurs them. I'm going to just focus here on the MA plans and ACOs. We have a lot of information on ACO, on Medicare Advantage overhead. We have relatively little. We know almost nothing about ACO overhead. And again, it's because most health policy analysts just are not interested in administrative costs. We have to look to people affiliated with PNHP over the years to look at the best research on administrative costs. But here's one example from the Lewin Group, a subsidiary of United Healthcare, reporting that that MCOs, managed care organizations, have to typically cut medical spending by 15% just to break even. Now, I want to eavesdrop on just a couple of earnings calls conducted by one of the original 53 DCEs, Oak Street. And the reason I'm going to do that is it's one place where I've learned that at least this ACO has a 20% overhead, just like a typical insurance company. Oak Street has contracts with several Medicare Advantage plans, including Centene and Humana, and I can't see behind the photograph who the other is. It was founded by 3 Boston Consulting Group colleagues, including the current CEO, Mike Picos. I think that's how you say it. Mr. Picos is worth $200 million, and he has an annual salary of $1 million to run this ACO. And its stock has not done well lately. Now, what's interesting about these transcripts of earnings calls is they tell you that the ACOs and the Wall Street analysts are really interested in the MLR, the medical loss ratio. And it's obvious why they should be. They want a really low medical loss ratio because that leaves lots of room for profit. They don't want a medical loss ratio like traditional Medicare's, which is 98%. You give Medicare $1 worth of taxes and Part B premiums, they keep 2 cents to run their shop. And they pay out 98 cents to doctors and hospitals. But you give $1 worth of taxes to these ACOs, it appears, and Medicare Advantage plans, they're going to keep at least 15%, maybe 20%, and give the rest to doctors and hospitals with strings attached. I don't have time to read each of these. I wish I did. These are really fascinating transcripts. But here you see an analyst named Justin Lake on the earnings call for Oak Street for the second quarter of 2021. These companies that trade on Wall Street feel obligated to hold phone conference calls with analysts with Goldman Sachs and Morgan Stanley and Piper Sandler and explain why their profit went up or down the last quarter and where they think profit will go in the next couple of quarters. So here you see Justin Lake with Wolf Research asking about their MLR, and you see Tim Cook, their chief financial officer, saying our MLR is probably around 80%. And Lake says, so right around 80%, Cook says yes. Here's the third quarter 2021 earnings call. Ricky Goldwasser with Morgan Stanley wants to know about the MLR. Here's Cook again. It's in the 81% range for 83 for quarter three. Here's the first quarter 22 earnings call. Here's Jamie Pearce with Goldman Sachs. He wants to know about the MLR. Interestingly, Cook says that the direct contracting has a higher MLR for them than their Medicare Advantage business. I'd love to know why that is. I have a theory. I won't take up your time tonight telling you. So he says, so the MLR, the medical loss ratio, is higher for direct contracting, but the revenue is higher. Medicare apparently is paying them more than Humana and the Cigna, the Medicare Advantage plans they contract with. So he says the per member per month dollars we get is comparable both on our direct contracting contracts with CMS and our contracts with Medicare Advantage plans. Now, if you want to know why Oak Street has administrative costs that are that high, well, here's one reason. This is an announcement on their webpage asking we need people to be utilization management physician reviewers. And what are they going to do? They're going to review all types of requests. Look at the list. So if you're a doctor, you're working with CMS, with Oak Street, you're going to be hearing a lot from their utilization reviewers. Not surprisingly, we have some evidence that ACOs drive up physician administrative costs. This is an excerpt from the final evaluation of the Pioneer ACO program, indicating that 3/4 of the physicians said they had to spend more time on paperwork. I include this slide just to indicate that Tim Cook at Oak Street says, we think we're fine with ACO-REACH. They're not worried about the changes CMS made after PNHP raised hell about the DCE program with CMS. Now let's just talk and think for a second what it means if CMS gets its wish and the entire Medicare program is privatized by 2030. If we have our wish and come 2030, Medicare is totally back to its original form, no ACOs, no Medicare Advantage plans, then what we're going to see is that Medicare, 98% of all Medicare revenues are going to be spent on patients and only 2% on overhead, and none of that on profit. But if Medicare is totally privatized by 2030, we're going to be seeing 85% at most spent on patients, possibly a lot less because CMS allows the ACOs to spend a lot less, and 15% or more will be spent on overhead. And doctors and hospitals are going to be spending more on administrative costs. And in order to sustain this, Medicare Advantage and hospital and ACOs are going to have to be overpaid, driving up Medicare's costs. And I think you all know the latest prediction is the Medicare Part A program will begin to be in the red 6 years from now. We need ACOs and Medicare Advantage like a hole in the head. Why do investors think ACOs will make money? off Medicare Advantage tactics. I'm going to go over this very quickly. Favorable selection. We've noted that it'll be a little harder for the ACOs to cherry pick, but they will be able to lemon drop, upcode, and deny services. I will just leave these slides for you to look at later. Congress and CMS has known for 40 years that a Medicare Advantage program has been vastly overpaid because they enroll healthier beneficiaries. Here's quotes from the U.S. General Accounting Office saying the HMOs are making out like bandits off of Medicare. And the reason why CMS has been unable to risk adjust Medicare Advantage premiums accurately is, as I said in my opening statement, the risk adjustment they used from 1972 to 2004 was extremely inaccurate. It explained only 1% of the variation in spending. After 2004, the diagnosis-based risk adjuster was introduced and phased in between 04 and 06. It's still highly inaccurate, explained only 12% of the variation, but it then made it possible for the Medicare Advantage plans to cheat in a new way. Upcoding. I'm not going to dally here, Terry, long. I want to show you how awful it is to have a risk adjuster that can only explain 1% of the variation. This graph shows you Medicare beneficiaries divided into quintiles. So this is the healthiest fifth of Medicare beneficiaries over to the sickest fifth, and we break it down to the sickest 1%. In the days before 2004, when CMS's risk adjuster could only predict 1% of the variation, they overpaid Medicare Advantage plans for a healthy beneficiary by $1.66. If they owed Humana $1 for this beneficiary, they paid them $2.66. Conversely, for the sickest 1%, they owed them $1, but they only paid them 17%. It doesn't take, you don't need to be a rocket science to understand that the way you make money off of Medicare Advantage is to cherry pick the healthy and avoid the sick. Now, what happened when CMS improved its risk adjuster to a magnificent 12%? Well, now when CMS owes Humana that $1, they only pay them $1.62, not $2.66. And whereas under the old risk adjuster, they were underpaying, they were only paying Humana, what did I say, 19 cents on the dollar. Now they're paying them 71 cents on the dollar. ACOs and Medicare Advantage plans worsen disparities. CMS should be talking about this, not crowing about how wonderful ACOs will be for equity. This chart shows you what happened after CMS implemented the diagnosis-based risk adjuster. Remember, it was implemented between 2004 and 2006. And look what happened to enrollment. It shot up. Now, I've never seen a study that says it shot up because now they could cheat like mad and upcode like mad. I think that's a reasonable inference. And of course, in 2022, this number is now 50%. Upcoding is happening, is at epidemic levels. This is an excerpt, let's see here, from NPR, reporting on a lawsuit against Group Health. I think in Seattle, I think the name has been changed. Group Health, for example, claimed that a man with who had an amazingly sunny disposition, according to his doctor, suffered from major depression. Kaiser Permanente is being investigated by DOJ for coercing its doctors to upcode. According to the DOJ complaint, Kaiser physicians allege that they are coerced to change medical records often months after care has been provided. More than half of Kaiser physicians said they were forced to add diagnoses they did not consider, evaluate, or treat. Cigna has been sued for, among other things, claiming that a patient had an active bladder cancer, when in fact the medical records showed a history of bladder cancer, but no recurrence, an ultrasound was negative, no hematuria or voiding issues were documented. This chart shows you how frantically ACOs upcoded during the physician group practice demonstration. The ACOs, their enrollees got sicker at almost twice the rate of the patients in the control group. I wanted to keep myself under 55 minutes. I'm going to give myself 2 more minutes here and stop. This is another quote from an earnings call transcript. You see here that CFO says that the problem is under documentation, that as they have more time with their assignees, they can document more and make more money off them. I mentioned the merit-based incentive payment system. It subsidizes ACOs. It needs to be stopped. This is an article from MedPage, September 12, reporting on a conference at which CMS officials were present, and the head of the ACO Association complained to them that the merit-based incentive payment system bonus is going to expire in 3 or 4 years. And he said, we've got to have that bonus. And a representative of one of the ACOs sat down with reporters after the conference and said that bonus is a knowable, plannable, countable dollar that goes directly to ACO participants. We've got to have it. I sure hope CMS starts reporting that subsidy when they tell us how much ACOs have saved. And I'm going to jump now to the end and take some questions. Here is my summary of the defects in the strategy refresh document. By 2021, CMS had compelling evidence to indicate that privatization is backfiring. It's raising Medicare's costs and reducing the quality of evidence. They utterly ignored that evidence. I find that actually kind of scary. CMS claimed it learned lessons from the Medicare Advantage and ACO programs, but it described no lessons. Instead, they presented vaguely articulated aspirations as if they were lessons. Medicare's Part A is projected to begin running a deficit in 2028. CMS should be educating Congress on the role that Medicare Advantage and ACOs are playing in driving up Medicare costs, not promoting privatization. And I leave you with some suggestions. We need to work, of course, to enact Medicare for all. We need to terminate or reduce overpayments to Medicare Advantage plans, but that's going to be difficult. They're going to go to their enrollees and say, these big members of Congress are trying to take away your benefits. So we need to couple that legislation with additional coverage for all beneficiaries. Traditional Medicare beneficiaries don't get now. We need to terminate all ACO programs. Please don't fall for the suggestions that it will be just fine if we let only nonprofit ACOs continue. We need to defund the Center for Medicare and Medicaid Innovation. That's the agency that Liz Fowler runs now. They're wasting our money. We need to terminate the merit-based incentive payment system. That will remove some of the incentive for doctors to join ACOs and make it harder for ACOs to survive. And we should kick insurance companies and ACOs out of state Medicaid programs. And I'll stop there.
Okay, if you have a question, raise your hand, and it looks like Corrine and Marshall have the first hands up. So Corrine.
Thank you. I have 4 questions. I still don't understand what Medicare Shared Savings is, even though it's one of the contenders for bankrupting Medicare, and how that works and how that's different from the ACO. And who pays for the MIPS, the merit-based incentive something. And I don't think a lot of doctors like it because there's a lot of things they have to fill out and it adds to all the paperwork. Another one is how you mentioned the relationship between the ACO and Medicare Advantage, how that's happening, where, from what I understand, seniors are being transferred from one program to another. If you could explain that a little. And then it seems to be people, right? The people who run CMS and CMMI. I understand CMMI is run by Liz Fowler and she has her own agenda. And CMS is run by Lakita LaShure, I forget her name. Why are they allowing this to happen? I mean, they're both, well, CMS is a doctor, the person running that. So I'm not quite sure what their connections are to the for-profit industry. So those are my 4 questions.
Well, good questions. I think if I understand your first question, you're asking me what the Medicare Shared Savings Program is. Yes.
How it differs.
it's a rather boring generic name. When Senator Baucus, with the help of Liz Fowler, who at the time was his assistant, wrote the Affordable Care Act, they wrote in two provisions that authorized ACOs. One provision said, CMS, you shall start an ACO program called Medicare Shared Savings Program. They had no discretion about that. They had to start it. And it started in 2012. And it is now the biggest of the programs. The other provision that the ACA included set up this innovation agency that was given $1 billion a year to dream up all kinds of value-based payment schemes to inflict on the traditional Medicare program. And it was this innovation center that dreamed up other ACO programs, including the names you saw up there, the Pioneer ACO program, the Next Generation program, and the latest scheme called the DCE REACH ACOs. So the answer to your question is the Medicare Shared Savings Program is a permanent program. It'll go on forever until Congress decides to take it down. The other programs, DCE, Next Generation, those programs CMS has the authority to terminate because that's how the ACA is written. Did I address the question you asked?
Well, what is it? Is it where the doctors are paid extra if they meet certain criteria?
I thought about explaining this and I've had so much to tell you already. I didn't. Well, let me tell you how ACOs are paid. So I explained the assignment process, right? There's this two-step process where patients are assigned to a doctor, depending upon which primary care doctor they saw over a 2 or 3 year look-back period. And then the CMS computers say, all right, if this doctor is an ACO, that beneficiary goes into the ACO. The next thing they do is they look back over the look-back period and they say, what did Medicare spend on these beneficiaries that were assigned to an ACO over the look-back period? And we're going to take our lousy risk adjustment method and see if we can estimate what the ACO should spend on these assignees in the coming year. And so to take 2022 as an example, they look back over 2020, 2021, and they project out what the Oak Street ACO should spend on these people. And at the end of the year, if the ACO spends over this projected amount, they suffer all the losses, the DCEs do, or they take home all the profit. Now that Medicare Shared Savings Program that we're talking about, the biggest one, they don't suffer all losses or take home all profits. They share the savings, and that's where it gets its name, the Medicare Shared Savings Program. If the ACO and a Medicare Shared Savings Program goes over the target, the budget for 2020, they split the loss with CMS. They send a check to CMS for half the loss. And if they go under, CMS sends them a check as a bonus, as a shared savings. All right, your second question, who pays for MIPS? The Medicare is a complex program, but essentially it's budget neutral, is my understanding. I haven't looked at this in a long time. Don McCann and I wrote about it even before it was enacted and said this isn't going to work, and we were right. But essentially, it comes from the Medicare Parts A and Part B trust funds, and it's revenue neutral. So if you score poorly, the stupid MIPS program scores every single doctor with a 100-point scale. They're going to measure your merit. And if you're over the median, you get some bonus. If you're under the median, you get penalized. I believe that this 5% bonus that operates from 2019 to 2020, I believe that's a separate pile of money, and I'm not sure where it comes from. And obviously, Congress didn't want it to run forever because, as you saw from that one slide, the ACOs are very concerned that Congress is going to let it run out. The MIPS program isn't going to stop in 2024, but that additional pot of money that makes ACO doctors so much richer on their Part B payments will run out. It's just ridiculous how complex this stuff is. Your third question, the ACO's relation to Medicare Advantage plans. some of these ACOs, not all of them, they've got their feet in both the Medicare Advantage business and in the ACO business. So Clover Health, for example, and Oak Street, well, let's just stick with Oak Street. Oak Street had contracts with Humana, or with Cigna and Centene, and I forget who else, maybe Humana. They would share some of the profits with these Medicare Advantage plans. I don't know the details of their contracts with them, but it appears that they get big money from these insurance companies by accepting risk from them, much as they accept risk from CMS through their direct contracting programs. That's their entire claim to fame, that they can get doctors across the country into contracts with MA plans and with CMS to bear risk, total risk, as if they were an insurance company. Not all of these ACOs that have not all ACOs that are in the direct contracting program have contracts with MA plans, but Oak Street does. And that may be what you heard. And it's what I commented on. And you may want to look at some of those, the transcripts of some of those earnings calls to hear the analysts and the chief financial officer and the CEO discuss these two branches, their direct contracting contracts and their MA contracts. Here's what I was trying to get at. There are reasons to think that the ACOs are not going to be as profitable as the Medicare Advantage plans. They can't cherry pick, and in theory, they're not supposed to keep their ACO assignees in network. It may be that the ACOs just can't rip off Medicare the way the MA plans did. It may be that investors are planning on these ACOs that have contracts with MA plans to use their relationships with their ACO assignees, encourage them to sign up with the MA plans with which the ACO has a contract. Now, I believe that they will be sued by the Department of Justice if they do that overtly. They're going to have to pretend that we just put some information up on a bulletin board and shoot, all these DCE assignees just mysteriously went over to Humana the next year. I am fairly sure if they do it overtly, they're violating the False Claims Act. But if you've heard about this issue, that's the question. Are the ACOs that also have contracts with MA plans using their relationships with the assignees to urge them to sign up with the MA plans so they can make money? You're not supposed to be getting kickbacks by referring people to doctors or MA plans under Medicare. And this would be seen as a kickback if they do it and get caught. Last question. Man, someone will get a Pulitzer who can answer that last question. Why do smart people do this? Why did Senator Kennedy buy Elwood's fairy tale about overuse and HMOs? Why did Liz Fowler write the ACO? I'm sure she had a hand in it, write the ACO provisions. And why 10 years later, when you've got evidence indicating ACOs don't work, do you push it? I don't know the answer really. I'll just offer this warning. I think we make a serious mistake if we think that everybody who promotes privatization is being paid to do it. I think there are intellectuals all over this country that simply believe the overuse diagnosis because they heard about it in grad school, read about it in JAMA, heard it from Senator Murray, and never hear anybody else saying that's bunk. And they believe it because the idea is powerful with them, like a religion. No one's paid to be a Christian or a Muslim. Liz endorsed it because the idea swept them up. I'm sorry it takes so long. Go ahead, Dave. Okay.
Marshall?
I want to just ask you another question. You haven't talked about the healthcare consumer. I thought my impression was the exponential rise in participation in Medicare Advantage was because of all these little incentives that the companies were offering, like dental and vision, hearing, and people think that they're getting a bargain. So tell us about the other side of the equation. Why is it that my generation, 65 and older, are drinking the Kool-Aid? I mean, they're as much responsible for the success of the MA proliferation as the promoters, the advertisers, the marketers, are they not?
They certainly play a role, and it isn't limited to the Medicare generation. I mean, HMOs gradually became very successful starting in the late 80s because as healthcare inflation really took off in the late 80s, suddenly everybody is willing to give up freedom of choice in order to get lower premiums. And we're seeing the Medicare generation make a similar decision. The healthier people are willing to give up freedom of choice in exchange for these better benefits that, of course, are only available because the Medicare Advantage plans are overpaid. I've got a younger brother who I told him, you don't want to get into a Medicare Advantage plan, and he signed up for it. I told my mother not to, and she never did. That's why she's now in an ACO. She wouldn't be in an ACO if she had been in Medicare Advantage. So yes, you can say that the elderly play a role in the success of the privatization of Medicare, and many of them are going to be an obstacle to our effort to reverse the privatization of Medicare. They're going to want to hang on to their extra benefits. But I would say, by and large, you can't blame them any more than you can blame the people that needed it. No, health insurance is a big ticket item. If people decide, all right, I got to put food on the table, I'm going to save a little money and join an HMO. I understand that.
Thank you.
Isn't there another thing that Congress prevented traditional Medicare from adding those benefits?
Yes, that's correct. Yeah.
And the Build Back Better and Permilla's bill would add them back to traditional.
Yes, I forget whose bill it was, but that was part of a couple of bills that have been introduced the last couple of years. I think they're absolutely essential to do that. It makes privatization harder to do.
All right, Kip, thank you. Wonderful work.
And
Wonderful work. My question really is twofold. How soon will your slideshow be available for us to use first? And secondly, I'm part of a meeting Friday morning with one of the members of our congressional delegation in person, Marilyn Strickland. And we have a good group going down, organized through Puget Sound Advocates for Retirement Action, a good group of beneficiaries, all advocating for getting rid of ACO-REACH. My question here is, what do you think about the idea of offering your slideshow to the Congresswoman and her staff without you presenting it? That's what I'm not sure of, because you do such a good job of explaining things. I'm not sure of the value of the slideshow by itself. So when and how to use it?
You're welcome to use it as soon as David gets it out to you. It's accurate. I don't think I left anything in there extraneous. But I have this, as I struggled with how much to put in there, that question did occur to me. How useful is this going to be to, say, a neutral observer who doesn't know a lot about this without my introduction? You might want to test it. Just ask somebody that wasn't here tonight, look it over, and see if they think it's that useful.
Right. Well, I was thinking in particular, I doubt if the Congresswoman would go through the whole thing, but her healthcare staff, I like to think, would be willing to go through it. And, I think one of its strengths is how much documentation there is of various studies.
Well, David, maybe the thing to do is just to summarize the major critique. I don't quite know how to do that in a slide. I did it in my opening statement. The original intellectual sins were to assume that overuse due to fee-for-service is the problem, and to make no inquiry into the size of the administrative costs of these entities that you think are going to reduce overuse. And you understand the bind then that the ACOs, the Medicare Advantage plans are in. You want them to cut overuse when there isn't much to cut, but in order to survive in Medicare, they've got to somehow cut medical services by at least 15%. I wouldn't take that bargain unless Liz Fowler told me, listen, we're going to overpay you a whole hell of a lot. Stick with us.
Yeah.
If we can summarize that ridiculous mistake or those twin mistakes early on and say, here's the evidence for it, maybe that slideshow would be understandable without hearing my explanation.
All right. Well, Mac, I'll follow up with you on getting a hold of the slideshow.
I'll make it very easy within the next 24 hours. So,
And there's a lot more, David. I mean, I struggle with My main problem I have with my presentation is that I have so much I'd like to tell people, and documentation, not me bloviating. There's more, there's more there if you need it.
We had Dr. Weisbert talk to us in April, and he said that these direct contracting entities were not really making much money. They were paying a fortune for these things. And so he said it was kind of like a mystery, like, why are they doing this? And he surmised that probably the end goal is by 2030, when they've completely privatized it, then they can sell it to United Health or whatever for a big profit. Do you agree with that? Do you think that's kind of what the end game is here?
That is such an interesting question. I mean, did you see the little line item I had on the chart, on the slide about Oak Street's the performance of their stock? It hasn't done well. The stock of a number of these ACOs, Bright Health, which has a great big skyscraper just a few miles west of me, is another ACO that's not doing well. Their CEO had to leave because the stockholders were not happy. It's conceivable to me that we will see the ACO industry will struggle, and I don't know what the exit will be. That scenario that you suggested is a plausible one to me.
It's the most logical conclusion, though, right?
It is, although I'm just trying to think about the legality of that. So what happens if Tender Mercy ACO says, we're running out of money, we propose to sell our assignees to United Healthcare? Boy.
I just threw that name out there. I don't know who they'll sell it to.
Yeah, I'm just picking an example too. I'm trying to think of, I mean, here's a good question. When my dentist decides to retire, she'll probably be able to get a good price for her practice because we all respect her, and whoever she sells to, we're going to say, okay, I'm willing to go there. Will ACO assignees feel any sense of loyalty? Will they want to go to United Health? I mean, how would you make them enroll?
Well, it'll probably be just retain the name Medicare, like we'll have, and then, Republicans get to come out, because inherently an insurance company will act like they do. Their evil nature will come out. They'll raise premiums. It'll be terrible service. And Republicans will be able to say there, see, government doesn't do anything better. Even though he'll have been like, we've privatized a social good, then we can just completely Medicare will basically be failing people probably, or not be very good. And then we could just really kick it to the curb,
Well, as I think about this, I don't know how it works. I don't know how Tender Mercy ACO says, well, we're going out of business, folks. We recommend that you sign up with Humana. I mean, if people wanted to sign up Humana, they would have.
So there may be no end game in your opinion?
Well, that isn't the end game. But the question you're asking is excellent, because it may be that investors don't know what they're doing. Private equity is often very good. It's going into, mobile homes or dermatology, buying up, getting out in 7 years and making a big bundle. I just don't quite see how they do it with ACOs, unless they develop the political might to get Congress to force CMS to overpay the ACOs. That, of course, is a possibility. But if the rules of the game don't change, I think there is a possibility that ACOs are not going to save a lot of money. Investors are going to get bored and go somewhere else.
I just became aware of the Improving Seniors Timely Access to Care Act that Congressman Del Bene sponsored and just passed the House. What I've been able to learn about it suggests that the makeup of the boards of directors of these ACOs would have to change so that 75% are from medical providers and 25%, 25% from financial interests or corporate interests. But other than that, I didn't see anything of substance in the act. It looked like a fig leaf to cover up for the ACO failures and make it look like Congress was doing something about it. Do you have any thoughts on that yet?
I haven't read the bill. I heard about it. As you may know, that's what that change in the board makeup is one of the cosmetic changes that CMS endorsed after PNHP raised hell about the direct contracting entities program. CMS said, well, okay, come January 1, 2023, 70% of the board members of the newly named REACH ACOs have to be doctors. everything's going to be better after that. Well, the problem with that is the doctors are on the take too. I mean, that they have the incentive that any board member has or the management has. I have no idea why CMS or any member of Congress would think that that's worth crowing about.
Yeah. That was the only tangible thing that I saw in the bill. The rest of it was a lot of the happy talk, like what you were reading from CMS, a lot of these same kind of verbiage about improving equity without saying how.
Yes, I just had a comment, and that is that I see the end point of Medicare is when everybody's in a private plan and then they switch it to a voucher. That you join Medicare and you get a voucher to spend on buying a private insurance entity of some sort.
Well, that could happen long before privatization is completed. You know, that's what the what was the name of that commission that met in 1999? Can't say the name of it, but they recommended vouchers. They wanted to recommend vouchers. They couldn't get the supermajority vote they needed. I think there were 17 commissioners. They needed a supermajority. They didn't get it. That happened in 1999. Then Paul Ryan came out. When was he there promoting vouchers? The Republicans are never going to stop promoting vouchers. So that's a threat, I think, at all times. And they don't need total privatization to promote vouchers. What they'll do is treat the remaining chunk of Medicare that's in the traditional Medicare program as a separate plan with its own vouchers. And of course, they will risk adjust the vouchers and very inaccurately. Fee-for-service program will be left with sicker people because the risk adjustment mechanism is awful. The traditional Medicare program will be vastly underpaid for its sicker people. The health plans that attract healthier people will be vastly overpaid. And eventually that will cause the traditional Medicare program to wither on the vine, to quote Newt Gingrich about 15 years ago when he was talking about the Paul Ryan plan. So that's a threat. Good point, but it's a threat that we face now. The Republicans don't need to wait for complete privatization.
And in addition to the suggestion that to turn Medicare into a voucher program instead of a guaranteed benefit, current crop of Republicans are suggesting that if they get power, they could move Medicare to the discretionary budget side of the federal budget, meaning that it would have to be reappropriated every whatever budget cycle. So it would be optional instead of guaranteed. So there are numerous ways for the people who oppose public programs like Medicare to put Medicare at risk.
This question reminds me, I want to just observe, I think it's well worth all of us becoming experts on risk adjustment. It usually makes eyes roll over, but it's well worth learning about it. Only the single payer movement doesn't have to worry about awful risk adjustment. But the Republicans promoting vouchers have to worry about it. All forms of managed care, anything that relies on capitation, ACOs, premium payments to Medicare Advantage, they have to rely on accurate risk adjustment, and it's never going to happen. They've been working on it for half a century. As I said in my presentation, at the best they're going to get to is a 12 to 13% accuracy rate, and only the single payer movement doesn't have to say, oh, here's our solution to lousy risk adjustment. Because we're not paying anybody capitation. We're paying fee for service and we're setting budgets for hospitals and nursing homes.
My point of bringing up the Republican scheme is to say that they have a proposal to put the entire program at risk.
Yes, I wasn't commenting on that. I just wanted to circle back to this
right
voucher risk adjustment issue.
Mm-hmm.
Well, capitation puts the risk on the providers, and that's an incentive to reduce the amount of care or upcode. So that's the key thing about capitation.
Yes.
Hi, I was just wondering, that presentation was extremely elucidating for me, very helpful. I'm in family practice, and this whole MIPS thing, I was kind of confused about what the heck that was. Anyways, I just wanted to say the REACH program, what you mentioned about the first part, what happened to your mom, I did not realize that part. that they choose who your primary care doctor is actually. That sounds really, really scary. And so does the 72% of privatized patients. I was just wondering if you see any hope, or what kind of hope you might see, or I guess that's my question. What do you think is going to happen? Are we going to get anywhere sometime soon, or if ever, or whatever you think?
Just a point of clarification. I didn't mean to suggest in talking about my mom's adventure that CMS picked her primary care doctor for her. What happened is she had an emergency visit. We thought she had COVID. She had an emergency visit to a hospital and wound up being getting a phone call after she was discharged. She had pneumonia, not COVID, from a nurse practitioner affiliated with the Health Partners ACO. And because she hadn't seen her regular doctor in that 2-year period, that one phone call from the Health Partners nurse practitioner tossed her into the Health Partners ACO. And I have her power of attorney, and I didn't know about it until last March when I got that one of those goofball, euphemistic, infuriatingly Orwellian letters. Your doctor has asked to join an ACO in order to provide the right care at the right time. And I had to actually work with a reporter at the Minneapolis Star-Tribune to figure out how the hell that happened. And I won't take up any more time tonight talking about it, but I'm on my high horse about it. It's an awful illustration of the problem. I'm encouraged by the resistance now that we're getting from PNHP, from Katie Porter, from Representative Jayapal and others, to at least the DCE program. My fear is some of the leading legislators are going to conclude that the problem is not really with all ACOs. It's just this one DCE REACH program, because it's being taken over by big private equity firms, big profit-making entities like Walgreens and Amazon. And if we can just keep those big for-profit monsters out, everything will be better. That's the Donald Berwick position, by the way. And I know that Pramila talks to him. I wish we could politely say to her, get him off your consultation list. He implemented the ACO program passionately and enthusiastically under the Obama administration. He's always going to be for ACOs. We cannot settle for just kicking out the bigger, nastier for-profit owners of ACOs. So that's my worst fear, is that this relatively new campaign against at least some part of the privatization juggernaut will peter out after we've done some incremental little reform that maybe eliminates all for-profit ACOs from the DCE program or something like that. And I must say, I don't know how Pramila is thinking or how Katie Porter is thinking. I wish all of you well in encouraging them to go beyond just thinking in terms of, well, it's this one DCE program bad because they allow them to make huge profits and there's some private equity ownership. We've got to denounce the entire ACO program and the entire Medicare Advantage program. Getting rid of ACO shouldn't be that difficult. I think we can do that. But boy, the power of the Medicare Advantage plans is something else. They got a lot of money, and now they have a lot of Medicare beneficiaries that they can communicate with. Here's something we should be planning for. Medicare Part A trust fund begins to go into the red in 6 years. We need to be pounding the drum. We are the fiscal disciplinarians. We value Medicare. You guys are wasting money on all this overhead on Medicare Advantage and ACOs. Do something now. And if you don't do it now, we're going to tell the world you are responsible for the increased Part B premiums and general revenue taxes that'll be required come 2026, or the cuts in benefits, if that's what the Republicans can make happen.
Okay, well, we've gotten close to your bedtime hour, and
Well, don't quit on account of me. I'm revved up, so let's stop when you guys have had enough.
You can have your Chardonnay then.
It's Cabernet.
Well, I'm having a Viognier.
Excellent, excellent.
Anybody
Thank you
else?
so much. That was so fabulous. I really, really was educated.
Well,
I mean,
thank you.
not that I was uneducated before, but this was like more drilled down and really clear. Thank you.
Well, I think when we go over the slides at our, when we have time, we can even get more out of this than we've already gotten, which it's dense. But
Yes, right.
Kip has the most dense mind in the whole country.
Well, I'm happy to take questions in any way you want to send them along.
Okay.
Well, that was not just dense, but it was really clear, I thought. It was very clear.
Well,
Thank you.
that's music to my ears. That's what I want to hear. Well, good luck, guys, and keep me posted. I'm
Thanks
really
again.
eager to see how you deal with the legislators you're talking about.
Yeah.
Well,
And
we
let's talk-
should talk to Pramila because we can talk to Pramila about whatever you said. What was it? Some guy that was like giving her bad advice. We need to tell her about that guy. What was his name?
His name is Donald Berwick, and I think it needs to be done diplomatically because I have the feeling she really trusts him. And he's an old time. I mean, he was in the Obama administration. That's why he has credibility with Democrats. He's well known amongst Democrats who work on the health policy committees.
But
So
she's really smart. She's really smart. I think somebody could talk to her. David, maybe.
yeah, so I wouldn't say to her, Kip Sullivan said Donald Berwick drank the ACO Kool-Aid and you can't trust him. I figure out some other way to.
I think she knows far more than I do about what's wrong with Berwick.
Well, I hope so. Good.
Say, if everybody wants to take a look at your chat, Dave Garibaldi attached the Medicare Advantage letter that hundreds and hundreds of members of Congress sign every year, praising Medicare Advantage and saying, yes, more of that, asking Health and Human Services or administration to again re-up and continue all the amazing programs and pluses within Medicare Advantage. This is the Kool-Aid Kip is talking about. I think you can read some of the buzzwords that they use, that they believe Medicare Advantage offers beneficiaries. What members of Congress need to understand is that none of this stuff has anything to do with insurance companies. These are benefits that their healthcare providers need to offer, like care coordination, in-home care, telehealth, other social needs.
Personal health care.
It's garbage. This has nothing to do with the insurance companies. This is what the healthcare delivery system is supposed to offer. And I think we have to educate members of Congress to understand that this is not provided by an insurance company. This is provided by either social services or the clinical side of healthcare. I don't know how this got so screwed up, but anyway, it's a good jumping off point for us to use to talk to our members of Congress. So if you guys look at Dave Garibaldi said Medicare Advantage letter of praise. It's not really, it's from Congress to Health and Human Services. And literally hundreds of members of Congress signed this, both sides of the aisle.
Yeah, I don't think Pramila did, but Ilhan Omar did. That's who
I
represents
know,
me.
I know.
Yeah.
They're all on the bandwagon, and we got to get them off the bandwagon.
Every Democrat, all 4 House Democrats from Minnesota signed that stupid letter. Yeah, good point, David.
Yeah, Dave, good. A friend of mine and I are in the movement here in Minnesota are going to meet with Tina Smith, staffer on aging, health and aging, or senior services next week. And we're going to try to disabuse her of the notion that Medicare Advantage has anything to do with serving seniors in any,
Pramila didn't sign on. She didn't sign on to that letter.
Well, anyway,
Okay, well,
This is a good insight into the language that the people selling Medicare Advantage are using.
Hey, Kip, it'd be great to follow up. I'm one of the board members on the Washington side. It'd be great to follow up through email with you. This was a really good presentation. If that's welcomed.
Yeah, I'd be glad to answer. And if you want to do this, I don't know, David McClanahan, if you can arrange this, I'd be happy to answer questions to the whole group. It might help, but my questions that occurred to you, Andrew, may have occurred to other people.
Tonight was your presentation was a good shot in the arm about how dire things are. I knew it would be.
Yeah, well, thank you. I'm sorry to say that.
Yeah, no, I mean, we need this. We need you to be here to like deliver the existential. I see the whole thing as an existential threat. So, but yeah, I hope we can follow up through, email. Yeah, maybe I'll leave it up to the board if we.
Kip, do you have any more presentations coming up in the next few weeks that you can just let me know about, and I can let other people know that something they might sign up on? Good. All right, I think we have to come to an end here, but it's just been wonderful for you to give up of your precious time. But it looks like you'll be able to sleep more or less, and then you'll get up at 4 o'clock and start stuff. All right.
Thanks for asking.
Okay.